tab that's an OCD program, we really want them to try to complete 70 to 75% of the hierarchy while they're with us, because our outcome studies show us that they can step down now to the next level of care. So, so when you treat a patient, if you look in our charts, there's actually a CBT in many of our programs, the actual CBT tab. And it'll have their hierarchy under it. It'll have their Psi box or Y box if they're an adult under it. So that can be really helpful to look at to really know what a patient's dealing with. Because as you see their exposures, now you really get to know what they're scared of. And now you really get to know about that person in terms of their OCD. They also have, some of them, you actually might see some of the children and adolescents. I don't think the adults do it, but children and adolescents, they can't keep track of a lot of things. So we put a little string around their neck with a little band book on there, not on the inpatient unit, but on residential and IOP. And in that book, we call it a band book or a stop behavior book. And what we're really doing is we're focusing on those rituals. So great, we're really super proud of them that they touch this table. But guess what they can't do? They can't wash their hands because then it will undo. Or if they're praying that I don't get sick while I'm doing the particular exposure, it's undoing. So what we coach them and want them to think is, this table is so dirty and I saw like 5 people touch it and I know it's really, really dirty. We want them to say, yeah, I want to feel the anxiety. So many of our patients with contamination will have hand washing bans, which is a really foreign concept in a hospital where we like to hand wash a lot, right? So these people cannot wash their hands the entire time that they're with us. So not after going to the bathroom, not after, well, they can't after art usually because they have paint on them. But really other than that, unless they have visible junk literally all over them that's seen by a staff, they cannot wash their hands. And guess what? They're okay. Even whenever we had the H1N1 epidemic, we had people on hand washing bans. Guess what? They were fine. So as much as we know that JCAHO and all those places want us to wash our hands, and it's important for us as we move between patients, really the world's a pretty safe place in a lot of ways. And so we'll have kids in residential for 2 months not wash their hands, except for when they take a shower. So these are the kind of things that we're looking to mark in our stop behavior book. So it might, or our band book. So it might be hand washing. It might be reassurance seeking. If it's a religious piece, it might be praying. And so what happens is we're asking them to track their submits and their resists. So this will mean, so the example here is reassurance requests. So if they ask for reassurance, if they think about it and they do it, they submit it to it. So we want them to write that down. If they thought about it and didn't do it, we want them to write it down as a resist. Now, what typically happens is when they first get here, we have tons of submits, right? They've been doing this a gazillion times before they got here, and they have very few resists. But as treatment progresses, we expect there to see very many resists and very few submits. So whatever that ritual is, we want them to track that so we can see. Not with the little ones. And probably, I would say the adolescents probably don't. So that's an important part. So you'll hear us say a lot, did you mark that down? I just saw you, that was a reassurance request. I need you to mark that down right now. And so they usually do. If they don't, then we just start tracking it and then we'll share it with them. But you definitely have to give kids rewards for doing that because, of course, they don't want to do it. They don't want to tell you. So yeah. Adults, I assume they don't really want to do it either, but if they're really motivated for treatment, they do a good job of it. So why do we do ERP? Well, it's incredibly effective. So in adults, of those who chose to participate in ERP, now you can imagine some people would be like, you want me to face my worst fears like every day for how long and do this like over and over? They think that's horrible, so some people will avoid it. But of those who do it, 80% experience significant improvement in their OCD symptoms. That's better than any medication I can give them. Remission rates for children and adolescents range from 40 to 85%, with gains sustained up to 18 months. That's huge, that it's a sustainable gain. And if they continue to practice and do it, then it can go even further. Parents are really important to make part of the team. We want them to be a coach, and they're taught ways to manage OCD. so that they can use it whenever it's coming up at home. And then we also use what are typically known as antidepressant medications combined with ERP because they have a synergistic effect. Cognitive restructuring is something that is done more in adults than kids. We certainly do it to some degree with kiddos. It just seems to be more effective in our adult population because they seem to just latch onto it more and understand it better. But we do this in addition to ERP. It's really a very classic form of CBT. What we're trying to do is identify specific thought errors that are going on with them. And so these are probably 3 of the most common ones that we see. Probability overestimation errors. So again, if I don't wash my hands, you'll hear some of these kids say, yeah, it's like 80% chance that I'm going to get cancer and die. I mean, so really irrational numbers. Catastrophizing errors. So if, I don't even know what that example is. But basically catastrophizing is, if one thing goes wrong, then your whole day is ruined. And then intolerance of uncertainty. This is in a lot of our patients with OCD where they want certainty all the time. They want to know exactly when something's going to happen or what's going to turn out the next day. They want to know, they just want everything to be very, very precise. They do not tolerate uncertainty, and our world is a pretty uncertain place. So those are forms of CBT that we use. Medications certainly are used with people with OCD. Some people who have mild, even moderate OCD can do ERP and CBT and not require medications. ERP is certainly considered the first-line treatment for it. However, if you have severe OCD or if someone chooses not to do ERP, then we may use medications. The important piece, though, is it's going to take a while for medications to work. It usually takes weeks to months, unfortunately. And then also, if we haven't taught them the skills, then when they stop medications, if their symptoms return, they're going to be faced with, am I going to do therapy or am I going to go back on medication again? So they won't have a skill set that moves forward with them, unfortunately. I'm not going to do a huge talk here on medication. I want to make sure I get to parts about how staff can help in this. But from a psychopharmacology standpoint, what we're usually going to do, this slide is just basically if you can't do therapy or you have a lot of other illness, then we're probably going to use medications. Or if you don't respond to what we would consider to be adequate trials of ERP, so 13 to 20 weeks of weekly CBT, and in children and adolescents, 2 to 4 weeks of CBT or partial response. So that's when we're going to consider medication. Combining treatments. Again, head-to-head, ERP is going to win out over medication in mild to moderate OCD. And then we do know that in moderate to severe that the combination of the two has a synergistic effect and wins out. If you have somebody who does CBT alone, medication alone, or the combination of the two, the combination is going to win out in adults and children. And so what we do is we use what people mostly know as SSRIs or antidepressants because serotonin is a major neurotransmitter that plays a role in OCD. So things that we know as like Prozac, Zoloft, Celexa, Lexapro, all of those kind of medications are going to be used in OCD. They typically require higher doses than is normal for, let's say, a typical adult or child who's depressed. So we use higher doses, and it takes longer to see if they're going to work. Can take 6, 8, 12 weeks, unfortunately, to see if a medication is going to work. There are many, many augmentation strategies that we use if they don't respond to an antidepressant. So we may add on atypical antipsychotics like Risperdal and Abilify. We may sometimes use a mood stabilizer like Depakote. You'll see some of us use a drug called Namenda that's actually used for people with Alzheimer's, but it affects glutamate. So there's a lot of different things that we can use. So sometimes, don't ever hesitate to ask us why, because you can imagine if I have a 10-year-old on Namenda, probably people are like, why is that? I don't think they have Alzheimer's, but it's for OCD treatment. Remission rates. When it comes to medications, about 50% of children and adolescents and adults will have what we consider to be a response. which means a 25 to 40% reduction in their symptoms. So it's good, but it's not great. And so we definitely want to combine it with ERP if possible, if it's available. Treatment resistance can mean, or the definition is to fail to respond to 2 adequate trials of a single class of medications. Usually we're talking about antidepressants there, or we only have a partial response at a maximum dose of something. So a lot of patients that make it here to us at Rogers, at least in residential, and some even in the IOP, are often treatment resistant. So that's we have sort of a skewed population here where we get more of that than probably other places because of our programs. So this is one of the most important parts to me, because I think as people move through levels of care, it's really important that we be able to work with these patients. So just thinking about different staff being involved in ERP. So of course for kids, they need more supervision often than adults. So helping coach them through the day is really important, making sure they're doing their exposure work, making sure they're tracking their band behaviors, watching to make sure they're truly doing the exposure. Like I said, this does not mean the same thing as this if I'm touching a contaminated table or item. So that's really important. So we all have to work together to do that part, which means also we have to be able to tolerate someone's distress. So if they're pretty anxious doing this and it's hard when an 8-year-old is touching this and they say, please don't make me do it again. That was really hard. You have to be able to work with them through that because that's part of their treatment. We don't want to force them to do something, but we want to see how we can help get them through that because they're able to do it. And so we also want to help with the accommodation piece. Just like families can accommodate patients, staff can too. An accommodation, no matter who it comes from, whether it's a teacher at school, whether it's mom or dad, or whether it's us, it's not helping their OCD. And one of the biggest ways that we can help is refusing their reassurance requests. And I have several slides that aren't actually on your paper that I'm happy to email out, but that I forgot to add before I sent it out to you guys. So we want to be aware of what their exposures and bands are. And we also don't want to, when you hear, like sometimes I see like, oh yeah, I'm on a hand washing ban, I haven't washed my hands for 2 months. People are like, oh. So we don't want to do that. We want to control our body language and be like, good job, that's awesome. Or do this like, oh, you must be really dirty. So we got to make sure we control our own body language. Reassurance is probably one of the areas that is the trickiest for people because, again, I feel like most people who go into this field and work here at Rogers are very compassionate people. They did this because they care about people. And again, we can reassure our friends, we can reassure our family members, and they're good with it and they move on. We have to remember these people don't function the same way. So why we think it's important is, number one, it gives the child a sense of independence and competence when they can learn to cope with their anxiety. They get super excited when they do it. We get super excited when they do it. And they just glow when they tackle some of these barriers that have just shut down their lives. So it also helps reduce the child's anxiety and quits feeding what we call the anxiety monster. The anxiety monster is insatiable. So it wants and wants and wants more. So we don't want to give it the fuel. And then we also know that, frankly, it gets exhausting over time. If a child wants you to ritualize over and over with them or give them reassurance all the time and it's never good enough, you're like, I don't know, I've said that like 100 times to you and you're still not getting it. But that's because it's about anxiety. It's not a rational thought. And we also have to be aware that we're also modeling for the parents how to help their child. So if we're providing a lot of reassurance, then the parents think, oh, I can do that too. So we don't want to give them that message. And why is it a problem to give reassurance? Just like I've mentioned before, it's a bottomless pit. You can provide, there's not enough, never. You could say it, I know Aaron and Eddie who work with me, we have kids who truly, their parents have said it 1,000,000 times, doesn't matter. They need it over and over. It's a never-ending cycle, feeds the anxiety monster, and it really undermines CBT because what it's doing is it's actually telling the child, yeah, there's danger. I keep addressing it. So clearly there's danger in this world, and we don't want them to think that. We want them to know that they can handle these problems on their own. And this is one of my favorite things when it comes to discerning whether a question is information or reassurance seeking. So our wonderful friends in St. Louis who send us a lot of patients and help us with other things, put together this little table. And I think it's really helpful because a question's not always a question with these people. So information seeking, you got to think about the left side. They ask the question once. They're doing it because they want to be informed. They accept your answer. They ask a person who's qualified to answer that question. So like, it would be weird, right, if a child came up and asked me how to solve an algebra equation, because I could not tell them that anymore. They ask questions that are unanswerable. They seek the truth if they're information seeking. They accept qualified or uncertain answers. And they pursue only the information necessary to form a conclusion or make a decision. Now, if we move to the right side of the table, totally different. Reassurance seekers ask the same question over and over and over and over and over again. They ask questions to feel less anxious. They respond to your answer by challenging the answer, arguing or insisting the answer be repeated or rephrased in some other way. So you didn't say it right, or you didn't do it with the right tone, or you didn't have the right body language when you answered it. They often ask people who are unqualified to answer the question. They often ask questions that are unanswerable, which is the same as information seeking. But they have a very desired answer. They really don't care. The truth is irrelevant to them. They have a very specific answer that they're looking for. They insist on absolute and definitive answers, whether it's appropriate or not. So they could ask me, Dr. Eakin, when am I going to die? I'd say, I don't know. I can't predict when you're going to die. No. I need you to tell me right now, when am I going to die? Is it going to be like tomorrow? Is it going to be 5 years? So it gets to those kind of questions, things that we truly have no idea, and that most kids would be like, oh yeah, of course you can't predict that. And then they indefinitely pursue the information without ever forming a conclusion or making a decision. So if anybody wants this table, I'm more than happy to provide it to you. I know it's not in your slides. So how can you reduce reassurance? Number one, you got to recognize it, which can be super, super hard. Even when a child asks a parent if they love them, that can be